Hello and welcome back to BunMed, where we discuss concise medical knowledge that we can fit inside of a bun. In today's video, we're going to have a look at the various blood products, their uses, and also some of the side effects and transfusion reactions that we may see. With that said, let's get straight into the video. So here we can see we have a test tube full of blood. So what's actually in our blood? Well, of course, we know that in our blood we have the cellular components, so things like our erythrocytes, our white blood cells, and our platelets. And as well as that, we know that these cells are existing within the plasma, and the plasma contains dissolved in it things like our proteins, so things like clotting factors, von Willebrand factor, antibodies, which not only determine what our blood group is, but also what diseases we have immunity against, and what proteins we may be allergic to, and also things like other proteins, so things like albumin, fibrinogen, and transferrin. And we can actually split up these components by spinning the blood very fast in a process known as centrifuging it. So if we centrifuge it, we actually see that we get it separate into three distinct layers. And on the very top, we have the lightest and the least dense layer, and this is the layer of plasma. And in it, like we said, it contains all of our clotting factors, our von Willebrand factor, some antibodies, and some other proteins. In the next layer down, the second densest layer, we can see that we have what's known as the buffy coat, this grey layer. And inside of this grey layer, we have things like our white cells and our platelets. And lastly, we have this red layer at the bottom, which mainly contains our erythrocytes, but it may have some white cells distributed inside of it as well. And we can actually use each of these layers specifically based on what our patient's pathology is and what they need to replenish what they've lost. So with that said, let's have a closer look at the plasma. So here we can see we have a bag of plasma. So what's the plasma actually made of? Well, 90% of the plasma, actually might be 91 to 92% of the plasma, is actually just water. The remainder consists of things like von Willebrand factor, clotting factors, and fibrinogen, as well as some other things such as electrolytes and other proteins that are involved in transportation. But the biggest one we're going to focus on is the clotting factors and von Willebrand factor. It's also got some other things that we don't potentially want to give to other people because we know our immune system is highly specific. And these things are like the donor's antibodies and the donor's antigens. So what actually is fresh frozen plasma? Well, fresh frozen plasma is when we take a bag of plasma and we freeze it at minus 30 degrees. And once it's frozen at minus 30 degrees, we can store it for up to 1 year. When we thaw it out, we aim to use it within about 24 hours. However, it may in some cases be stored for up to 5 days after thawing. So what do we actually use FFP for? Well, let's have a look at, again, how what it's made of links into what we use it for. So we know it's 90% water, and therefore we can actually use it to replenish some of the water that we may have lost or some of the liquid or volume that we may have lost in an acute bleed. So especially if our patient has had hypotension, which is low blood pressure after a bleed, we can use FFP to bring their blood pressure back up. Now you're probably wondering, hang on, this isn't the first thing that we do. Whenever we have a bleed, we start off with things like saline, or sodium chloride, or another crystalloid, and absolutely that's bang on right. We only tend to use FFP if our patient is showing low blood pressure along with signs of a coagulopathy. So they may be having difficulty forming blood clots. And this could be shown if we do some clotting studies and they have things like a high PT or a high APTT. Because if we have a high PT or a high APTT, it suggests that we've lost quite a lot of our clotting factors and therefore our clotting cascade is actually impaired. So therefore giving FFP will help to replace that. Another thing that we can use FFP for is hemodilution due to its high content of water. And essentially what this means is that if we have given too much electrolytes or too concentrated electrolytes or even too much red cells, we can use FFP to actually dilute the blood down a bit. Okay, now let's get into the nitty-gritty bit of FFP, because this is the biggest thing that we're going to be using it for, and that's using it in bleeding conditions, because it is so rich in the clotting factors and von Willebrand factor. And an ideal example of this is something like disseminated intravascular coagulation, or DIC, where we're forming inappropriate and uncontrolled clots all over our body, which is using up all of our clotting factors. Giving FFP helps to replenish all of these factors and stops the patient from spontaneously bleeding and therefore may be life-saving. Another case where we can use FFP is in things like thrombotic thrombocytopenic purpura. There's a typo there, it should say purpura, not purpuric. And essentially we use this after we've done a plasma exchange just to help replenish some of the clotting factors that they may have lost during the disease process. Another time we may give FFP is if the patient has a difficulty forming these clotting factors or forming fibrinogen in cases like liver disease, because remember, most of our clotting factors are actually formed inside of our liver. So therefore, if we have liver disease and issue with synthesis of the factors, we can give it in the form of FFP just to replace those. And this may also be done in abnormalities where we have a congenital deficiency of these factors and we can't produce them. So that's the main uses of FFP. What are some side effects? Well, we can see that we have donor antigens and donor antibodies. We also know that each of our immune system is highly specific to ourselves and will very much react to anything that is not from us. So therefore, we might get very, very commonly things like allergic reactions and more rarely things like anaphylaxis. So how does this happen? Well, let's say, for instance, we have the donor's antigen or the antibody. In this case, we have the donor's antibody. And in our recipient's blood, we have a protein that the donor was allergic to. So therefore, their antibody and the recipient's antigen are going to go and form lots and lots of these antigen-antibody complexes. And this will set off an allergic reaction. In the mild cases of an allergic reaction, we might get things like itching, or another word for it is pruritus, or things like urticarial rashes or wheals where we have swollen areas over our arms that tend to go away. And this is usually due to histamine release. However, in more severe cases of anaphylaxis, we might get things like angioedema, which is swelling of the face or the tongue, and also this might block off our airway. Another sign of airway obstruction might be stridor, which sounds a little bit like this. And we might also get things like dyspnea, which is difficulty breathing. Now, our heart's going to try to compensate for this, and it's going to do this by altering how quickly it beats. So we're going to get a tachycardia. And because we have so much histamine release, our blood vessels become very, very leaky, so we tend to get hypotension. Now, anaphylaxis may specifically be seen more commonly in people who have an underlying IgA deficiency, and therefore they develop anti-IgA antibodies. Another issue that we may face with antibodies is specifically if we have a type of antibody known as the anti-HLA antibody, which goes on to give us things like transfusion-associated lung injury, or TRALI for short. Here, our anti-HLA antibody goes on to stimulate our recipient's white blood cells, specifically the neutrophils, and these neutrophils can then go attack the lung. And once they attack the lung, they actually cause fluid to spill out from the capillary inside of our lungs, causing fluid to build up within the lungs, or giving us pulmonary edema. Because it doesn't involve the heart, this is known as non-cardiogenic pulmonary edema. So some symptoms of this, the biggest one is going to be things like dyspnea. When you put on a pulse oximeter, you'll see that the patient is actually hypoxic, so they'll be deficient in oxygen. Another thing that you might see is they'll have low blood pressure. Another thing that you might find is crackles on their chest when you're listening with a stethoscope, and this again shows that we have fluid buildup in our lungs. And when we do a chest x-ray, we'll see bilateral infiltrates, which is scattered white opacities. Opacity simply just means white shadows all across our lung fields on both lungs. So that's TRALI. If we give the fluid too quickly or we give fluid too much fluid, we might actually get something like transfusion-associated cardiac overload or something like TACO. And in this case, we give too much fluid or fluid too quickly, and our heart simply can't keep up with the demand of this all. Now, because we've given too much fluid, we actually tend to get hypertension, not hypotension. We might get things like difficulty breathing and dyspnea. Things like crackles over our chest because our heart is failing, and therefore this is causing our pulmonary circulation, so all of the blood traveling through our lungs, to actually become stagnant and backloaded. So all of the pressure is going backwards through our lungs, and this might cause fluid to spill out into our lungs. And we might also get things like peripheral pitting edema, where we have a lot of the fluid that was inside of our blood initially actually escaped outside of our blood and into our extracellular matrix. So the concentrations of our clotting factors and our von Willebrand factor and our fibrinogen is actually very, very similar to that of our own plasma. So the recipient's plasma that's receiving the FFP will have the same amount or the same concentration of the clotting factors in the donor's FFP. But what if our patient has bled so much, or what if our patient has such a bad bleeding disorder or such a degree of bleeding disorder that they need even higher concentrations of our clotting factors? Well, this is when cryoprecipitate comes into handy. So what is cryoprecipitate? It's essentially very, very concentrated plasma. In fact, it's about 5 units of plasma that go on to form 1 unit of cryoprecipitate. And essentially, it contains very, very high levels of the protein fibrinogen. Remember, fibrinogen is needed to help us stabilize that platelet plug by forming that fibrin sheath. It also contains smaller amounts of things like von Willebrand factor and some clotting factors like factor 8 and factor 13. Now, because it contains really high levels of fibrinogen, we can use it in conditions where we have low levels of fibrinogen in the blood, or hypofibrinogenemia. And a classic example of this is something like disseminated intravascular coagulation. Again, remember, we're getting so many uncontrolled clots being chucked out all over our body. We're using up our fibrinogen. So therefore, if it's suspected that a patient has DIC, it's very much worth doing a fibrinogen level and then replenishing their fibrinogen if it's low with something like cryoprecipitate. We can also use it to replenish other clotting factors. So in something like von Willebrand disease, something like hemophilia, or something like congenital factor 13 deficiency, we can actually use cryoprecipitate only if the first line alternative is not available. So what do I mean by this? Well, in something like hemophilia A, we actually have factor 8 concentrate, octocog alpha, without the need for all of the other stuff in here. And there's a much lower risk of a transfusion reaction. So therefore, we should use that first line. Only when is this not available can we start thinking about using something like cryoprecipitate or even something like fresh frozen plasma. And the same goes for von Willebrand disease. We have recombinant von Willebrand factor, and we also have things like desmopressin before we even need to go to cryoprecipitate. So it's very important to remember it's not the first line, but it can be used if the alternatives are not available. So what kind of side effects or kind of transfusion reactions might we expect with cryoprecipitate? Well, it's just concentrated plasma, so therefore it's still going to have some of the antibodies and the antigens that we saw from earlier on when we were looking at FFP. So you can still expect things like an allergic or an anaphylactic reaction, and we may have antibodies, again, anti-HLA antibodies against our lungs, which may go on to cause things like TRALI or transfusion-associated lung injury. Another blood product that I wanted to discuss is Prothrombin Complex Concentrate, or PCC. So what is PCC? Well, unlike all of the other stuff that we've seen so far, this is actually a powder, and that we can make that into a solution and give IV. So what's actually in this powder? Well, it contains the factors, clotting factors 2, 7, 9, and 10. Also known as the vitamin K dependent clotting factors. So essentially it's a dry powder containing all of the vitamin K dependent factors. So when do we actually use it and why is it really useful? Well, this is absolutely fantastic for helping us reverse the action of warfarin when we've over anticoagulated with warfarin. I haven't discussed warfarin in great depth yet, and I plan to on a future video coming up quite soon. But essentially, the way that warfarin works is by inhibiting an enzyme known as vitamin K reductase, essentially shutting off how vitamin K can function within the body. And therefore, it stops the function of factors 2, 7, 9, and 10, which depend on vitamin K acting normally. If we've anticoagulated with warfarin, our vitamin K is not functioning properly. Therefore, our clotting factors 2, 7, 9, and 10 inside of our body are not going to be working properly. So one way we can get around this is by actually giving those factors back in the form of prothrombin complex concentrate. So when do we actually classify as over anticoagulation with warfarin? Well, on warfarin, it's any time you have a bleed within the brain or within the abdominal cavity itself or any critical site. This is considered severe or life-threatening bleeding, and you can give something like prothrombin complex concentrate to reverse this, and you may also give it alongside something like intravenous vitamin K just to reverse some of the action of that warfarin. What's some of the side effects of giving this PCC? Well, remember, we're actually giving a lot more clotting factors than the body is used to. So it's only obvious that we're going to see a higher percentage or a higher chance of thrombotic events, so things like pulmonary embolisms or even DVTs in the venous system. In the arterial system, we might get things like strokes if we get a embolus being lodged inside of our of our brain, or we might get something like a myocardial infarction if it happens in one of the coronary arteries of our heart. Right, let's round off this video by having a look at the platelets. So here you can see we have a bag of platelets, and of course they're going to have to be in some sort of solution. So in this case it's plasma, which is what it is in most cases. So what do we use platelets for? Well, it's obvious we use platelets to replenish platelets that we've lost, right? But there's a caveat to this that we have to be aware of. So firstly, let's see in what cases and what guidelines can we use platelets. So the first condition we can give a transfusion of platelets in is something like disseminated intravascular coagulation, again because we're forming uncontrolled clots all over our body that's using up our platelets. Now let's get into the nitty-gritty guidelines. So these are the guidelines from NICE in the UK, so National Institute of Clinical Evidence. It might be different across the world, but in the UK, it's this. So if we have a look at the first one, and this is for critical sites of bleeding, so things like your brain or your eyes, we tend to consider giving platelets if our platelet count falls below 100. The next one where we might consider giving a bag of platelets is if we have clinically significant bleeding. So this is when we have lost about 15 to 30% of our blood. So our patient has tachycardia, which means a fast heart rate. The heart rate is compensating for the blood loss, so their blood pressure hasn't quite dropped yet. So if they have a tachycardia and they're normotensive and their platelets are below 30, you can consider giving a bag of platelets. And lastly, we can give platelets prophylactically if our patient has a platelet count of 10 or under, just to stop them spontaneously bleeding or bruising. Now, there are some conditions which is a bit mind-boggling that you wouldn't think you couldn't use platelets in, but platelets are actually contraindicated in. And the first of this condition, contraindications, is things like thrombotic thrombocytopenic purpura. Now remember, we discussed TTP to be the condition where you have dysfunctional ADAMS13 activity. It's an enzyme that helps cleave von Willebrand factor. And as such, the activated von Willebrand factor reacts with all of the platelets nearby and forms lots and lots of clots. So if we gave platelets, we'll just simply be forming more clots, and there would be a higher risk of thromboses. The next time you can't give it is in something like idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura, because the antibodies are simply going to break them down. And lastly, you can't give it in heparin-induced thrombocytopenia, again for a very similar reason to that of TTP, because if you did, the antibodies would simply just react with platelet factor 4 on the new platelets that they've been given and simply end up causing more and more clots. So what kind of side effects might we see in a platelet transfusion? Well, you may have noticed that within our bag of platelets, we have some white cells, because remember in the Buffy coat, we found white cells as well as our platelets. And this is quite scary, as this may go on to cause something like graft versus host disease. Essentially what graft versus host disease is when we transfuse a recipient with the donor's platelets, there are some or red cells, there are some white cells left over. So we will call this the donor's white blood cells. And the donor's white blood cell will meet the recipient's white blood cell. And once they interact, the donor's white blood cell will not recognize the recipient's white blood cell, and it will recognize it as foreign and multiply and produce antibodies to destroy the owner's blood cell, the recipient's blood cells. And therefore, this is an absolutely terrifying condition, as you can go on to get things like disquamination of the skin being one of the early features, where the skin literally pulls off. If it affects your abdominal system, you might get things like nausea, vomiting, or abdominal cramps. And if it affects your kidney or your liver, you might get jaundice or renal failure. And the mortality in graft versus host disease is really, really high. So in order to reduce this, what's done to the platelets is they're irradiated with radiation. And this kills off some of the white blood cells, leaving just the platelets behind. Another side effect that you might see is an increased risk of bacteremia, which means increased bacteria in the blood, or sepsis. And this is because platelets are actually stored at room temperature, around about 25 degrees. And bacteria love to multiply at room temperatures. So therefore, there's a much higher risk of bacteremia or sepsis. And the thing is, with platelets, they have a shelf life of about 5 days because they are stored at room temperature, so they must be used up within 5 days of collection. Now, of course, you can see that our platelets are actually submerged in some plasma, so we may have some donor proteins left over in that plasma, again leading to things like anaphylaxis or an allergic reaction. We may also have those anti-HLA antibodies leading to things like TRALI. And, of course, because there's bags of platelets, we may give too much platelets too quickly, or give the backup platelet too quickly to a failing heart or a frail heart, and this can lead to TACO as well, or transfusion-associated cardiac overload. So that concludes our blood products video. In the next video, we will be having a look at the red cell, a packed red cell transfusion, but also looking at the treatment to some of these transfusion reactions. Hope you've enjoyed the video. Please feel free to share to help the channel grow, and please feel free to subscribe as well. If you have any questions, please pop them down in the comments below, and I'll try to get back to you as soon as possible. Thank you.